Welcome everybody. This is week 9 of our course. One of my favorite topics, topic related to philosophy of medicine, medical philosophy, therapeutic relationship and alliance, and the patient as an individual. Now, this is one of those lectures that would warrant much more in-depth and profound discussion. So in the slideshow, I did my best to focus on the most important topics from a theoretical perspective. But of course, more discussions is warranted and expected. So any feedback you have, it's really appreciated. And as usual, feel free to email me. I'll be happy to answer any question that might arise as part of our examination of the topics thereby included. Let's begin. The first slide is about therapeutic relationship and alliance. By this term, we also include, of course, patient-provider relationship. Now, let's begin with the standardization process. So therapy, group attendance, and standardization. It is important to always put the patient at the center of our intervention. It is thus helpful to keep the communication channels open and ask questions. For instance, focus groups, surveys, and questionnaires. This area of our analysis focuses on therapeutic intervention in the context of multidisciplinary treatment team. And this also means that there should be a way for us to understand concepts such as productivity and whether these business model related concepts can be applicable to healthcare. In other words, should we focus on how much are our patients involved in our interventions simply from the statistical perspective of how many patients attend therapy, let's say each day or each week or each month or each year? Or is there something else that we should understand? Now, this question has been asked because, of course, from the perspective of public health, we are not only focusing on the single individual, we are focusing on a community, we are focusing on society as a whole. And one way to understand that is also to ask patients, and therefore contemplating the combination between quantitative and qualitative research, and ask questions such as, did you enjoy the therapy? Now, this can be a slippery slope, as you can imagine, because by did you enjoy the therapy, we should be able to distinguish efficacy, effectiveness, and efficiency of what we propose, as opposed to what is perceived as beneficial by the patient. In other words, there is an area of scientific investigation that is warranted irrespectively from what the current situation is. In other words, without the presence of ontological validity from the perspective of patient satisfaction. So in other words, we have to be able to separate whether a medication, a form of psychotherapy, an intervention works, even before we had the chance to ask the patient how they felt about it. But at the same time, because as we will see, there is a component of interpretation in everything we administer to our patients, we should not discard how our patients feel about the whole process. And this is connected to what we examine in the next slide. Important concepts: white coat syndrome, placebo effect, nocebo effect, role model, and right. So let's start from the first one, white coat syndrome. Well, let me just start by saying that this is not a syndrome in a clinical sense of the term. It's not a full diagnosis, of course. By white coat syndrome or white coat anxiety, we simply refer to the emotional state a person might find himself or herself in when faced with the possibility of entering a hospital and communicating with a healthcare provider, for instance, a doctor. Now, this is also predicated upon cultural factors. Doctors are usually perceived as either very smart or a combination of very smart and possibly judgmental, because after all, we are seeing a doctor, a healthcare practitioner, in order to get more information about how we are performing to some extent, whereby performance we mean how well our homeostatic processes in our body are appearing, okay? How far off from our biological, psychological baseline we might find ourselves in. And so there is some level of anxiety facing that. Plus, the anxiety can also be related to some possible bad news that the doctor might communicate to us. Bad news that might be in turn indicative of congenital problem, genetically transmitted issues, as well as poor behavioral choices on our part. And as I mentioned this in the past, this has to do with the nature-nurture debate, right? If everything was simply, so to speak, based on nature, this could make us feel better in a moment because we are not fully responsible for our poor health in the moment. We're not, we should not feel guilty because we did not play a part in that. It was our body that reacted a certain way. And yet this is ultimately very detrimental to our psychological well-being because we might feel that there is something wrong to begin with our body. It adds another burden. So this will be the nature component. On the opposite side, a fully nurture-based analysis will obtain the opposite psychological effect. Namely, there's nothing intrinsically wrong with your body, with its system, but you made a series of very poor, ineffective choices about your health, and therefore you will have now to pay the price, which is also, of course, not very ideal. Okay, so in any case, meaning a provider, meaning a doctor, comes with a sense of burden. Okay, on top of it, there are cultural factors as well. In the United States, for instance, a medical school is considered overall a difficult field, a difficult academic program, and therefore for a person who is not a member of that academic program, or did not have experience to study in a program, meeting with a healthcare provider might be intimidating. Okay, this is what we mean by white coat syndrome. They might, of course, have a series of negative effects in terms of how negatively will affect our heart rate, for instance, respiratory system, etc., etc. Okay? Placebo effect versus nocebo effect. This is pretty straightforward. The term placebo, it's derived from Latin, placeo, so I shall please, I will please, all right? Future tense. And nocebo, the opposite. I shan't please, I shall not please. Okay, what do we mean by please? I shall not produce a positive effect. Okay, so it will be produced in the concept of placebo, and it will not be produced in the concept of nocebo. Now, this term in itself is something that overall, from the perspective of Western biomedical models, it's not optimal. We have to account for the placebo or nocebo effect in order to verify and quantify whether that treatment actually works or not. In other cultural frameworks, the placebo and nocebo effect are the essential effect for every therapy. Okay? So the fact that in the concept of placebo, there are forces that are producing a certain positive results, okay, not completely separated from the biological factor, but at least not primary influence. If nothing else, might be influencing, okay, those forces. And nocebo, the opposite. There might be some negative forces that are activated. Whether these negative forces are visible or they can be detected with a laboratory analysis, this is connected to the very last notion here, role model versus right, or role model dash right, or and right. What do we mean by that? Well, in our modern society, especially in the West, the doctor, especially the primary care provider who has the control, who's in charge of the chain of command, is psychologically, ritualistically, anthropologically speaking, a substitute, okay, at least subconsciously so, of the role that in traditional societies a shaman would have embodied, for instance, or a spiritual guide, or a chieftain in a tribe. Okay, so it represents, or a priest, or a rabbi, or an imam. So it represents a go-to archetype for a person that in itself plays a fundamental role. To give an example, whether a person is administering medication based on a recommendation found, I don't know, among friends, the medication itself will have an effect, but effect will be either enhanced or, in the opposite term, will be decreased in its efficacy. And again, we have to separate efficacy, efficiency, and effectiveness. Whether the medication itself was directly administered by a role model, okay, by the chieftain in a psychopractitioner sense, so by a doctor. Okay, so we have to keep that in mind when we are trying to understand the therapeutic relationship. First of all, to avoid unnecessary hierarchy or perceived hierarchies, where the doctor is judging the patient without displaying an appropriate sense of cohesion and empathy and understanding and positive regard. Okay, but at the same time, making sure that we are clear in the way we present the information, so we don't assume that the word, the jargon that we utilize is fully understood by the patient. So avoiding any unnecessarily complex terms that will contribute to this separation between patient and provider. To give an example, in psychiatry, none of us utilizes wide codes on the unit to achieve just that, this connection between patient and provider, instead of adding a further wall, a further separation. Now, this, of course, predicting upon a Western model. It is also true in other sociocultural framework, this sense of hierarchy can also be beneficial, because, again, if we are embodying a ritualistic modality and an archetypal modality, then we need to at least rely on this higher regard that in those societies certain figures have, so that it is not focused on the individual, but it's focused on the role that, in this case, the doctor is playing. Okay, and so this can have beneficial effects, because again, it's predicted upon something much higher. Part 3, examples of question asked as part of a focus group addendum. This is connected to the research presented in the textbook, and it represents this approach, this open-minded, nurturing, positive regard-based approach toward our patients. So those are some of the questions. First, while on inpatient psychiatry, what does a typical day look like for you? This question targets the complexity of interaction that occurs on a daily basis in this type of unit, and also serve the purpose of trying to avoid missing important pieces of information. First of all, related to pharmacological and psychotherapeutic intervention, medications, individual session, group therapy session, but also the connection between these approaches and the support of social workers and LNA, LPNs, possible communication that occurs via telephone or telemedicine with external outpatient providers, etc. Number 2, what is your favorite part of the day? This is important, especially from a psychiatric standpoint, because we had to work on mood, emotions, cognitive processes that are in turn related to our intervention. So it's also good to know whether the presentation has some sort of cognitive emotional pattern in any given week. 3, what is your least favorite part of the day? For the same reason, but coming from the opposite direction, to understand whether the patient, for instance, might be more prone to request a PRN, let's say in the evening, for instance, or if there are any other process that might be a partial justification of the change in mood and emotional presentation, gastrointestinally related, for instance, or anxiety related to the presence of a morning meeting, for instance, etc., etc. 4 and 5, group therapy. What do you like about group and what do you dislike about group? Now, this is especially important in the context of group therapy from a psychotherapeutic standpoint, but also group in general. In many units, we have other models of intervention based, for instance, on open dialogue or patient-centered clinical rounds, when the decision-making process is conducted in front of the patient in the presence of multiple treatment team members, especially physicians, nursing staff, psychologists, etc., but also to monitor possible post-discharge planning, okay? And also from the perspective of providing the patient with an extra level of insight to the type of decisions that are made, having the patient at the center of the intervention. 6 and 7, group activities. Which are your favorite and which are your least favorite? Now, this is important from the perspective of the connection between what is considered therapy. Again, within the realm of psychiatry, we tend to think of psychiatry as pharmacological intervention and psychotherapeutic intervention, but also activities in general. We should never underestimate the power of peer support, or the negative effect, peer pressure, for instance, or even outside of most commonly observed mood effectors. For instance, whether a patient might be more or less prone to accept a clinical recommendation before or after this person talked to his or her roommate, for instance. Okay, so it's providing an extra level of insight. 8, if you do not go to group, what do you do during that time? Now, this can be a very judgmental question, and one of the advice that I have for future application of these type of focus groups is probably rephrasing and rewording this type of sentence and utilizing a more balanced approach, an approach that can be taken from motivational interviewing. We will talk about this discipline again in the future, especially in motivational interviewing. Think about the OARS acronym, OARS, where the O stands for open-ended question. Okay, so rather than having this judgmental attitude that which might not be our intent, might be perceived as such by our patients, utilizing a more nurturing way to frame the sentence that could provide further opportunities. Okay, and of course this can also be related to the tone of the question. If the question was asked verbally, whether I'm saying, so if you do not go to group, what do you do during that time? This might be felt as more judgmental, as opposed to, so if you don't go to group, what do you do during that time? Which can be perceived as more nurturing instead. Okay? But in any case, trying to figure out ways to establish a rapport with our patients. This is extremely important in any subfield of healthcare. If we do not have the opportunity to establish a rapport with our patients, that all our efforts will be in vain. Okay? So the most important thing is to actually have the chance to communicate with our patients. Okay? And that has to be achieved in a nurturing, positive way. Number 9, while on inpatient psychiatry, when are you bored? Now, this is specifically important from the perspective of clinical diagnostics and therapy. And it might be less important, but not completely not important in other fields, because boredom is very much connected to depression. Okay, so we could say that being overwhelmed, with having too many things on your plate, can lead to anxiety, can lead to stress, immediate or chronic stress, can lead to feeling that you cannot catch up, and this can in turn constitute a destabilizing, dissociating even situation where you feel that your whole world is collapsing and you kind of crash under the weight of these multiple things you need to attend to. But the opposite is also detrimental. When you're, so to speak, underwhelmed rather than overwhelmed, you don't have as many things to do, not because of the real presence of these things or your perceived absence of these things, but because if you don't have enough stimulation, your horizon is somewhat flat, as in absent, as in not motivating, as in deprived of a purpose or meaning. Okay, so being too stressed with too many things to do, or the opposite, not having enough to do, not any direction, can lead to boredom. And with boredom, the associated cognitive and emotional process is very often depressive-like. Okay, it can create a sense of desperation, disillusion, disenchantment, cynical self, lack of direction, and so on and so forth. So it's important to understand that we have to make sure that our patients are attended to even outside of the time where we're actually doing something, so to speak, clinically relevant from our perspective. Everything is therapy once a patient is admitted to a hospital. Number 10, similarly, all right, but to understand what else can we provide in order to match the emotional state of the patient. When you're bored at home, what do you usually do to entertain yourself? Okay, what else can you share with us so that we can better provide the necessary care while you're here? Okay. Finally, number 11, what would motivate you to attend group? Okay, so again, here we are not judging the decision-making process, the ability to make appropriate decisions, but we simply are displaying an interest in seeing what else could we do in order to achieve that goal. Okay, so there are different ways to approach that, and again, this has to do both with an overall attitude to our patients that we should all keep in mind, but also with some skill set, which we will discuss further when we talk about things such as nursing, especially health and wellness coaching, motivational interviewing, and so on and so forth. Now, since we're talking about interactions, let's take a look, again, from the perspective of inpatient psychiatry at the type of interaction in terms of sequence, in terms of process that few fundamental treatment team members, healthcare providers, usually utilize in order to provide treatment to our patients. So let's begin with the first slide, the psychotherapist or group therapist, the psychologist as well. Quick note here, of course, it is important to understand the unit structure and the workflow of the treatment. So what usually happens if you are a psychotherapist working in a hospital? And again, between psychotherapists, group therapists, psychoanalysts, psychologists, etc., psychiatrists, and so forth, I will encourage you to take a look at the differences in professions, as we described previously, and we'll continue to describe at the end of the lecture. But for now, keep in mind that this workflow is specifically indicated and described for an inpatient psychiatric psychotherapist or inpatient psychiatric group psychotherapist, group therapist. So first thing, the person, the doctor, the psychotherapist meets with a patient, then arrow down, check in with patient. Is patient in their room, okay? Or is the person meeting with another healthcare provider, another team member? Are there visitors? Are they in the common area or eating a meal? So if they are in the room, yes, inform patient group is happening and invite them, okay? So invite this patient to attend the group that is offered. And usually, in general, we recommend inviting patients to group at least 10-15 minutes before the beginning of the group. But in any case, after the schedule for that day has been already shared with every patient early, or as early as possible in the morning, okay? Instead, if the patient is not in the room, do not interact with patient. And this is fundamental. It might be common sense, but we should never interrupt one another. Okay, so a psychiatrist should never interrupt a psychotherapist or vice versa. A nurse should not invite a patient when the social worker is meeting with them. Whether there is an emergency, of course, the psychotherapist and the psychiatrist are two primary figures usually that are intervening in an emergency situation. So emergency aside, each treatment team member is and should be allowed to do his or her work in full capacity without interruption. Now, as you can imagine, if it's a psychiatrist to interrupt a nurse during the administration of medication, that could also have detrimental consequences for the pharmacological intervention. And the same thing for a psychotherapist in the middle of a psychological evaluation or an assessment or a therapy. If the therapy is interrupted, that can also have very significant negative effect for the rest of the admission for the patient, and potentially traumatic effects also upon discharge. Now, if instead it's yes, we're back to the bottom, informed patient group is happening, invite this patient. Does the patient attend group? If the patient does not attend group, do not interact with patients, namely We don't add pressure at the moment because the pressure might be perceived as triggering, might be perceived as shaming, okay? So we have to wait until the end of that intervention, pharmacological, psychotherapeutic, before we might want to interact with the patient again at the end and try to provide support and also investigate reasons why they didn't want to attend. If yes, interact with patient during group as expected, and of course write up on group, and this has to do with writing clinical notes, SOAP notes, progress notes, EHR, etc., etc. Let's continue with nursing stuff. Another wonderful example of interaction between team members, and of course, I dare to say that nurses are probably one of the most important treatment team members in the hospital. So what happens here? The RN, the registered nurse, meets with patients. Is the patient available? If the patient is not, do not meet with the patient at this time. Okay, and so again, try at a different time for the same reason as we mentioned previously, so as not to disrupt the intervention of other treatment team member. If the patient is available, is the patient engaging? Okay, and this has to do with a variety of things. Maybe the patient is not able to engage because the patient is still recovering from surgery, for instance, okay? And so do not meet with the patient this time, or the patient is not presenting with an appropriate mood, overall emotional and cognitive presentation, for which the nurse might not be able to provide the necessary clinical support, unless the nurse, of course, has further clinical expertise, certifications, etc., in clinical psychology, for instance, okay? Or if the patient is unable to interact due to a psychotic presentation or other neurologically and other medical clinically relevant situation. The patient might be in a comatose state, in a locked-in syndrome, etc., for which the patient might not be able alone to provide the necessary care. Okay, and so another treatment team members might be called to support this interaction, maybe a physician, or maybe a psychologist and doctor, etc., etc. If the patient is engaging, and of course, the patient might not necessarily want to engage with the treatment team members, might not want to engage with doctors or nurses, or might not want to engage with that specific treatment team member at that time, okay? So we had to provide the best possible care, not to trigger negative emotion in our patients, and we might want to ask if they will be interested in meeting someone else, for instance, okay? So if the patient is indeed engaging, checking with patient and write up. So the follow-up is always clinical notes. Now, this is important for two perspectives. One is to provide the most direct, precise, and scientifically accurate way to describe the interaction, okay? But also to promote and defend patients' rights, privacy, and safety, as well as the privacy, safety, and clinical intervention of the provider, okay? Now, to continue, let's examine some of the clinical interventions utilized in an inpatient psychiatry unit. I mentioned multiple times in this semester that to teach healthcare and to teach it in a way that is taking into account the work of multiple members, multiple providers, multiple professions, the inpatient psychiatry unit is one of those places in any given hospital that really presents a solid interaction between treatment team members. So let's see how an average week looks in an inpatient psychiatry unit from the perspective of the main therapeutic intervention, so psychotherapy, group therapy. First example here is a week, Monday through Sunday, that specify different types of intervention. Now you will see that there are some areas that are purposely left blank when there is no interaction, or there are times in between sessions. Now, the times where things are left blank, those are left blank because each treatment team member has the opportunity to have time to meet patients individually for clinical assessment and individual therapy sessions, okay? And of course, there are times in between sessions to allow patients to relax and rest and process information they received in each of the groups, okay? Now, you do also have some areas reserved. For instance, you see Saturday at 11:15, and those areas are also reserved for clinical intervention in combination with research methods, okay? When the leaders of the research department, especially psychotherapists, are able to conduct research and provide further scientific investigation to the unit. So you see that many days, in fact, most of the week starts with a check-in, and in the evening you have the corresponding evening check-in. In these groups, we usually investigate how the patient's night went in the morning and how the day went in the evening, whether they were able to sleep, whether they were able to interact, what groups they attended, what interaction they had, positive or negative, how would they rate their mood, their overall day on a scale. We use a Likert scale, 1 to 10, with 1 being a very bad day, a bad mood, and 10 be the best possible mood, the best day they could ever have. And then we, depending on which interaction, we also ask whether they have specific questions that have not been yet addressed previously with their treatment team members, or they have any interest in discussing this or that topic throughout the day. So it's a good icebreaker, it's a good way to start a day, it's also a good way to conclude the day before the evening. Now, of course, in the evening, we also have games or leisure activities, depending on the current situation. Of course, during a pandemic, the offering might change and might be more theoretical rather than focus on open arts and crafts or board games, for instance. But in the end, the idea is that there should be a leisure element that could also provide a sense of normalcy while being on the unit, especially in the context of psychiatry. This is extremely important, okay? Now, we also have volunteer-based interventions that are, while they're not necessarily diagnostic or clinical in the therapeutic sense of the term, they are support groups. So you find pet therapy, for instance, on Monday, 11:15. You have a recovery group on Friday evening, and the recovery group, it's a group that is focused on AA or NA, so Alcoholic Anonymous or Narcotic Anonymous support groups, okay? Then we have groups such as yoga, for instance, on Friday morning. We have hybrid groups such as the Saturday coffee talk, sometimes also offered on Sunday, okay? And then we have clinical interventions, usually at the central part, in the central part of the day. So you may have psychotherapy from 11:15 all the way to the 3:30 group. So you have exercise group, you have grief group, CBT, cognitive behavioral therapy, REP, so wellness and recovery action plan. You have mindfulness, you have addiction recovery, which is different than the recovery group, because in the addiction recovery group, you usually target either neural underpinnings of behavior, so basic neurobiology. You target motivational interviewing elements, CBT, DBT, etc., support. You have art therapy, which is very different, of course, from arts and crafts from a leisure perspective. You have DBT, dialectic behavioral therapy. You have stress reduction, Tai Chi Chuan, self-esteem, and you have other groups that are not listed here, such as ACT, for instance. You have groups such as positive affirmations. You might have narrative medicine, etc., etc. And in the next slide, you see another example. So it's slightly different, but with the same structure overall. The general idea is that we want to make sure we have a balanced approach to the group offering, so that you have a CBT group followed by another CBT group immediately after, so the day after. So there are 2 days in between, for instance. We have groups that are combined, so you might have mindfulness and meditation. You might have specific areas of DBT or DBT plus life skill groups, such as communication skills. You might have Tai Chi combined with mindfulness. You might have supportive relationship. You might have spiritual care groups or philosophy groups, and so on and so forth. Now, there's always room for focus. In this example, you see it on Friday at 11:15, okay? And this is offered every week to make sure that patients have enough time to process information, and each patient has at least a chance to obtain a focus group survey during the admission, especially for patients that might be on the unit for a relatively limited amount of time, a short period, like a week or less. Okay, so at least every week, at least once, we have a focus group, and then medication education that focuses on pharmacology intervention and, as the name implies, educating patients about their medication. So this is overall a standard week as created by group therapists. Now, of course, while group therapists and psychotherapists play a fundamental role, an essential role for therapy, you have a lot of other support team present that provide, again, clinical interventions outside of the main intervention, which is represented by group sessions or individual sessions as well. Wonderful. So let's move on to part 2 of this lecture. The patient as an individual. In the second part of the semester, we will analyze some theoretical constructs and elements that serve the purpose of providing insight and further information in the field of health. So let's see what we mean by the patient as an individual. What do we mean by treating a person first, even before that this person is considered and labeled as patient? The person-patient is the next initial premise. From a philosophical standpoint, one of the most important aspects of using a mind-body approach in psychiatry is that the focus on a type of Giddens double hermeneutics faced with Levinas' other. In other words, there is a or one mind-body that interacts with another or another one mind-body to establish and benefit from a therapeutic relationship. And what do we mean by that? Well, by Giddens, we mean Anthony Giddens, double hermeneutics, the philosopher on top, the slide above, Emmanuel Levinas, the other philosopher, the French philosopher. And we mean double hermeneutic in a sense of double interpretation and effect. Double hermeneutic, from the perspective of medicine, the perspective of nursing, the perspective of healthcare, means just that, the interpretation that happens from the provider to the patient. So me as a doctor, am I interpreting what I'm seeing accurately, precisely, and with a high level of insight, scientific knowledge, meaning can I interpret what I observe from a diagnostic standpoint with a certain degree of accuracy, but also how do I present myself as a provider, okay? What is my interpretation of the patient because I am a provider, because I'm a doctor, okay? And the opposite, what is the perception of the patient and how is the patient interacting with me? So double hermeneutic as in this double effect, double connection and representation between patient and provider, okay? If you want to find more, I will encourage you to research double hermeneutic, especially the work by Anthony Giddens. Emmanuel Levinas, it's a wonderful philosophical analysis of this concept of the otherness. This is a very complex and beautifully complex philosophical concept for which I only want to mention just a very few basic things. The general idea is that I know myself as a person more, and you could argue only insofar as I am reflected in the other person, not necessarily reflected as in a response mechanism, okay, as a reflection / refraction. I become the other person, but the other person informs me, okay, shapes me. So this concept of otherness, okay, the other is the ultimate goal to achieve a sense of self, but also from the perspective of healthcare to achieve a better outcome in our therapeutic intervention, okay? Now, what do we mean by there is a mind-body interacts with another mind-body? We mean two things. We mean that there is a mind-body, so me as a nurse, for instance, as a doctor, etc., that possess a body, the way I present myself, as well as a mind, a cognitive process that allows me to interpret situation, okay? And I'm interacting using the same underlying structure than the person in front of me has. And if you're interested, by that I mean especially things such as cognitive processes on one side, but also emotional and cognitive processes as the one predicted upon the work by mirror neurons, for instance. And in the concept of mirror neurons, I really encourage you to search the research by Giacomo Rizzolatti, for instance, on mirror neurons in the 90s at the University of Padua. But in any case, on one side you have the person-patient interaction, two bodies, two minds, okay? But also one specific type of mind-body interaction, how my embodied cognition affects the other person, okay? Whether my whole self of self matches the self of the other person. Now, let's be sure here, we're not talking about changing myself for the sake of appearing what I'm not, okay? We're not talking about hiding certain emotional display from the perspective of being appropriate, proper, and professional. This is certainly part of our job, to be professional in our presentation, in the way we utilize words and our overall attitude. Sure, that is absolutely important, but it's also about matching the client. Okay, so there is a match of metalinguistic approaches. Okay, so for instance, poor versus good eye contact, whether the patient is open and this openness is displayed by, for instance, not having their arm crossed. Okay, all the way to our tone of voice, the words we use, etc. So we need to be closer to our patient in order to achieve the goal, which is in the end communication. So this is the initial premise. There are many other philosophical approaches that we could consider, but this is just a start to present this perspective. Part two, the self as part of the whole. Okay, we talk about the patient as an individual here. Okay. The Latin term individuum, okay, refers to the concept of indivisible, okay, individuum, similar to the Greek atom, atomos. Indivisible one is a patient that is made up of all these pieces of the organismic puzzle, okay, mind, body, and spirit and soul, and experiences and cognitive patterns and previous processes and traumas or lack thereof and expectations and disappointments and physical presentation and so on and so forth. Indivisible, okay? This is also important from a psychotherapeutic standpoint, because if we're indivisible, we're less prone to become divisible, and in more intense situation, this divided self turns into separated self, into dissociative self, into schizophrenic self, etc., etc. Okay, so indivisible as well as integrated. Okay, self. The other term, single, from Latin singulus, refers to the term sine, without, as privative. Okay, so removing something, or sasam, Greek sum, as in symbol, right? S-Y-M, which means unity. Okay, we talked about sin with when we talk about medical terminology, synesthesia, for instance, synesthetic, okay, syntax, etc., etc. Finally, person, patient. The Latin term persona, from the Etruscan persu, is linked to the value that a particular element has on the individual. Etymologically speaking, the term persona, person, is a combination of per plus sona, per plus sona. It has the mask face that the individual wears in order to change the sound of his or her voice and his or her physical appearance, okay? Now, you have an image here of what we mean by that, the mask that in the Greek tragedy, in ancient Greek Roman theater, the actor utilized to achieve that effect, okay? So this is just an overall description of what it means to treat a patient as a person. You have a concept of complexity, indivisible complexity. You have the unity of the term. And finally, you have the way they present, okay? Which it should not be viewed only as a mask, as in the negative sense of the term, but the way a person presents herself or himself to the external world. All right, patient-provider relation and involvement in clinical care. All right, let's take a look at this aspect. The very descriptor excuse for attending groups, excuse for therapy, as opposed to had intent to participate in groups, to participate in therapy, has been directly associated with the items above. Now, the items above, of course, what we talked about patient-provider relationship, all the way to the schemes that we discussed when we analyze the process of meeting with the patient, okay? What happens if we combine, mistakenly so, excuse as opposed to had intent? We had to navigate that because, first of all, we have to understand the reason why a patient might not want to engage in therapy, or whether there are situations that arose that we were not aware of. And that's why clinical treatment team communication is so essential. The statistical analysis which followed the first research, and I really advise you to take a look at the textbook to compare the first research with the second one, which is a comparative analysis in terms of, again, group attendance and standardization, have quantified and qualified the core issues behind low group attendance, while at the same time indicate those areas which should be considered therapeutically helpful and effective beyond concepts such as productivity. We thus want to refer to the correlation between attendance, self-perception, spirituality or religion, therapeutic effectiveness, and mind-body connection. Now, for each of these areas, we had in patient psychiatry, but this model has been progressively expanded upon different hospital units, okay? We have the ability to understand what to do to empower our patients to better take care of their own health, but also to communicate with the rest of the team more appropriately, more precisely. We understand self-perception as in what is the role I am playing as a patient, as a person, okay? Because I certainly play a role, not because I'm hiding something, but because I am an essential part of this equation, patient-provider. Spirituality or religion for a variety of things. We mentioned that previously, but we'll talk about that at the end of this slideshow as well. What is my understanding of what makes me healthier? Okay, is it the medication? Is it the doctor? Is it God? What is it? Okay, so we have to at least understand where our patients come from. Therapeutic effectiveness, the opposite. So whether the therapy we provided, it works, or is it still working? Did it stop working, or it doesn't work as well as it used to be before? And I'm talking especially about pharmacological intervention. And finally, mind-body connection, where the patient finds himself on this spectrum at the moment of our intervention. All right. To provide a more balanced, integrative, and holistic approach to care, okay, mind-body medicine, MBM plus CM, complementary alternative medicine, monitoring patients' presentation, affect, and health status is essential. Healthcare providers can utilize quantitative analysis, for instance, we talked about this in week 2, and qualitative analysis, for instance, questionnaires and surveys. As an example, this is a very commonly used Likert scale for this type of analysis, this qualitative analysis with surveys. Please score each item on the following scale from 1, absolutely disagree, to 8, absolutely agree, right? Now, of course, there are study protocols, study design elements, bias control elements, a randomization of words, order, etc. to take into account. But this is at least a way to help the patient quantify what they feel and think during the administration of the questionnaire. Few more slides. Example question, utilizing the Likert scale that we just seen. How much do you think your health depends on? This is a question that we asked as part of the research unit. How much do you think your health depends on destiny, medications, therapy, therapists and psychiatrists, randomness, external factors, you as you, brain chemistry, and genetic predisposition? Now, of course, this is a very summary-like, oversimplified notion of all these areas. Okay, we could certainly agree that destiny is too vague of a term, and by destiny we don't necessarily mean a predestined situation, and where free will or free want or veto power plays a role here. Whether we should be more specific about therapists as doctor and psychiatrists as physician, for instance, whether randomness makes sense only in the context of a previously assumed non-random world, whether brain chemistry, for instance, it's limiting because we are not considering the full spectrum of electrochemical or magnetic presentation, etc., etc. But those are areas that are at least easier to understand for a broad analysis from the the vast majority of people, and provide us with an insight into how to approach each person, not to assume things, not to project things. For instance, our system of beliefs does not, should not affect patient-provider relationships in the concept of providing care, and also to have a better way to achieve the goal, which from our perspective is not necessarily to tell patients what to do, and the concept of motivation interviewing will play, we will analyze that role quite a bit, but also to have the chance to understand where the patient comes from. Now, the very last slide for this week, it's going to be a bridge to the following week, and also the next 2 or 3 slideshows and lectures. So in this slide, you see a scatter plot subsample of the correlation between believing God and your ability to get better according to the statistical analysis of medical philosophy. Okay? The reference and the bibliographical reference are contained in the syllabus. Now, you might wonder what even bring up to the conversation, to our analysis, system of beliefs in a course on healthcare. What's the purpose and how ethical it is to talk about things connected to spirituality and religion, for instance, when we are teaching students how to learn healthcare-related skills? Well, the reason is pretty straightforward. The reason is that this is one of those areas that is very much playing a significant role in the self-perception of the vast majority of patients. And here's the thing: first of all, in this context, God is it's a one-size-fits-all type of term, and of course, we are not intending here to distinguish theological differences between deism and theism, or lack thereof, of the opposite, agnostic perspective, atheistic perspective, reductionist perspective, etc., etc. The key element here is that healthcare and medical sciences, as it implies, are based on science, and so of course, science in the concept of empirically based biological model or biopsychosocial model does not need to rely on any of these assumptions for it to work biomedically speaking. Okay, so in other words, our therapeutic intervention, psychotherapy, and pharmacological intervention, and surgical intervention, etc., whole spectrum of medicine works regardless of the patient's system of belief or lack thereof. But it's important to understand that the research is pretty straightforward. We at least have to acknowledge the presence of a type of worldview in our patients. Okay? Now, we will discuss this further in the next slides, but it's quite interesting that there is a significant high level and connection, in this case, of course, correlation. We're not talking about causal effects. We're not suggesting that the more a person feels empowered and in charge of their well-being, the more they're prone to believe in God, or the opposite. The more they believe in God, the more they feel in charge of their health, and they can develop further skills. But at least this correlation is quite significant. Okay, this is just a scatter plot subsample of the correlation, this analysis. But you'll see that there is quite a connection in multiple studies. For instance, in the context of psychiatry, the vast majority of studies, and for the specific studies and meta-analysis, again referred to the textbook, clearly indicate that a solidly based spiritual religious connection plays a significant positive role in the treatment of depression, in how strong negative emotions and cognitive process will affect the person, or how successfully the person might relapse, might recover from a relapse, for instance, in the context of suicidality, of desperation, of addiction disorder, etc. Okay, so the vast majority of studies clearly indicate that there are positive effects. Now, of course, this is
not an ontological question, does not prove anything. This is beyond the realm of science, and we should not, mix this magisteria. We're not suggesting that this is an apology in the theological sense for the belief in higher power and God, etc. But we should at least keep in mind that this correlation is quite strong. And so in our therapeutic effectiveness, we should at least contemplate having a dialogue with the patient, simply to understand where they're coming from. We're not here to educate them. This is not our role. There are, for instance, spiritual care departments in any hospital, nor should we enforce or try to suggest the likelihood that a patient should embrace our worldview. We should refrain from that from a perspective of privacy and ethics, etc., etc. But we should definitely be well informed of the connection between these factors. So I will conclude here. This is a short lecture just to open up the conversation, and then in week 10 through 13 we'll have the chance to talk about this specific topic much more in depth.
So this slide concludes week number 9 PowerPoint. Thank you again, and I will see you in week 10.